Education is the most powerful weapon which you can use to change the world. It's a quote from Nelson Mandela. Welcome to AHS Guide, your trusted companion for mastering anatomy, physiology, biochemistry, pathology and microbiology with clarity and with easy understanding. If you're preparing for exams or just curious about how the human body works, you're in the right place. Now, so in today's video, we'll be studying about physiology and the topic is blood. Blood is a specialized connective tissue that we have learned in the anatomy. So here we'll be studying about the physiology of how the blood works. So it is a specialized connective tissue, as I told, and it acts as a vital transportation system in your body. What all does it do? It delivers oxygen, brings the nutrients to the tissues, removes the waste products from the cells or tissues, and it plays an important role for immunity. So your body immunity is dependent on the blood transport system. It also has a role in homeostasis and clotting. So homeostasis is the normal blood flow that happens in your blood vessels, and clotting is going to stop the blood seepage or blood flow that is causing excessive blood flow. So in an average adult, how much do you think is the amount of blood? It is 5 liters in an average adult, which consists of plasma and other types of elements like red blood cells, white blood cells, platelets, which we have covered in the previous videos. Go to AHS Guide, go to the playlists, and you can see a physiology blood chapter wherein I have uploaded all the other videos, other topics that have been importantly put into syllabus by Rajiv Gandhi University. So go through those videos and come back to this video. This is a continuity of the blood chapter. Now let us start with today's topic. So here you can see a picture. There is a division of the girl's face into a proper normal color body skin tone, and there is a yellowish color. So by the picture you can understand that it is about jaundice. So jaundice is a yellowish discoloration of the skin or the sclera and the mucous membrane. Sclera is the eye, and mucous membrane caused by the increased amount of bilirubin levels inside the blood. So this disease itself has an underlying condition wherein the liver is dysfunctioned and the hemolysis is happening, or maybe there is an obstruction of the bile flow from the liver into the intestine and through the feces. So there might be the condition might be due to dysfunction of the liver, or in the hemolysis, the breaking of the red blood cells, or due to the obstruction of bile flow. The bile might be accumulating in the human body itself rather than being thrown out through the fecal matter. And we'll also be exploring about the definition of jaundice, its causes, and what is the reason for the jaundice to happen. So firstly, here we have the definition of jaundice. We'll read the definition. Jaundice is a yellow discoloration of the skin, sclera and mucous membranes caused due to the increased serum bilirubin level inside the body, inside the blood. So it might be, if the bilirubin is greater than 2.5 milligram per deciliter, then it is said to be a jaundice. So remember the normal levels and the increased levels that might cause the jaundice. Now what is the reason or what is the cause for jaundice to happen? Because of the accumulation of bilirubin in the blood, it causes a disruption or disturbance in the metabolism or excretion of the bilirubin from the body. Whenever bilirubin is building up inside the body or is accumulating inside the body, there is a disruption or there is a change in the normal metabolism or excretion of the bilirubin. These bilirubin try to accumulate inside the blood vessels and in the body, causing the yellow discoloration. So in Kannada, I guess you guys know it is called Kamala Roga. So in English it is called jaundice. So the classification of jaundice, we can see there are three main types of jaundice. The first one is prehepatic jaundice, which is called as hemolytic as well. This is caused due to the breakdown of red blood cells, or the red blood cells are blasting inside the body itself, which is hemolysis that is happening inside the normal blood vessels. The bilirubin type is mainly unconjugated bilirubin. It is an indirect bilirubin. So whenever the red blood cells is carrying a bilirubin inside it and transporting it into the fecal matter through the osmosis, it might cause the bilirubin to be released inside the blood vessels itself, causing the yellowing of the skin or serum or the mucous membranes. So what are the tests to detect the prehepatic jaundice, which is liver function test? So that is one type of test wherein you take out the liver enzymes and check for the normal levels of the liver enzymes that are being secreted, and if there are abnormality in the liver enzymes, then it is considered to be jaundice. So this is a test that is used to rule out the jaundice. We'll see the image later. Firstly, we'll go through all the three types. Now, what are the common causes for prehepatic jaundice are hemolytic anemia, as I told, because of the breakdown of the RBCs in the blood vessels. It can be due to sickle cell disease as well. Sickle cell is wherein the blood cells appears to be like sickle. In Kannada, kudugolu. Like kudugolu. If it is like kudugolu, then the blood cell disease is called as sickle cell disease. Thalassemia is also a type of a blood anemic disorder that we'll be seeing in pathology, so don't worry about it right now. Just know there are two types of hemolytic anemia that could be the cause for prehepatic jaundice. Moving to the second type of common cause, which is malaria. Everybody know malaria is being transported by the vector mosquito. So malaria is also a deadly disease that causes jaundice. Jaundice are the symptoms of malaria as well. Now, spherocytosis, then G6PD deficiency. So, spherocytosis, as you break sphere, cytosis is breaking down of the cell. So RBCs are broken down and the bilirubin is released inside the body, or the toxins that are present inside the blood vessels, RBCs are released into the blood directly, causing the prehepatic jaundice. Now, G6PD deficiency is a type of deficiency due to the lack of glucose 6-phosphate dehydrogenase. It is a genetic disorder. So if in case G6PD is not produced, the RBC's outer protective layer is not produced. When the RBC protective layer is not produced, the RBCs tend to blast or break down because of no protective layer, which is a glutathione. If you want to do a little research of G6PD deficiency, you can go and search in Google and learn about it. So we'll just know the important points of common causes in here. So hemolytic anemia, malaria, spherocytosis, G6PD deficiency are the common causes for prehepatic jaundice. Now, how can you determine the prehepatic jaundice? By looking at the urine color. So urine test, we have done it in pathology already. The video is being uploaded for the various clinical tests that are performed and what are the normal and abnormal levels. How are you going to detect? Everything is covered in that video. Go back to AHS guide, see in the playlist, search for the pathology, or you can search for the link down in the description as well. I'll put a link of the video as well. You can go and see what are the tests that are done for various body fluids, interstitial fluids as well. Now, coming back to the topic, urine color when it is normal. And how is it? Unconjugated bilirubin is not water soluble. So since you can detect unconjugated bilirubin by performing certain tests, and you can find out that the prehepatic jaundice might be there. It is a test that is conducted, but you can't observe in a normal naked eye because the urine color appears to be normal. Now, stool color is also normal, and sometimes it might be dark due to the increased urobilinogen. So urobilinogen causes the dark color of the stool as well. Now, moving to the second type of jaundice, which is hepatic jaundice or hepatocellular jaundice. Now, what are the causes for this? Is there is an impaired uptake, conjugation, or excretion of bilirubin due to the damage of the liver cells. So there is a damage of liver cells which is causing then impaired uptake, which is taking up of the bilirubin or production of the bilirubin or excretion of the bilirubin through the liver cells is damaged. That is what you have to know. And bilirubin types are both conjugated and unconjugated under hepatic jaundice. So both conjugated and unconjugated bilirubins can be increased at elevated levels. Now what are the liver function tests showing? They are going to show you elevated ALT or AST. So liver function tests will show an elevated levels of ALT and AST. Now what is ALT? ALT is an alanine aminotransferase enzyme and AST is aspartate aminotransferase enzyme. So these are the two enzymes that are being secreted from the liver. If in case their levels are high, it is said to be the hepatic jaundice. There are chances the hepatic jaundice may be in that person. So what are the causes for the hepatic jaundice? It could be viral hepatitis A, hepatitis B, hepatitis C. So it can be HIV, HBV, HCV, any of them. That can be the cause for hepatic jaundice. Alcoholic liver disease as well. The people who consume alcohol also might have damage of the liver cells causing the hepatic jaundice. Now drug-induced liver injury, people who consume more of drugs, that is the OCT, which is over-the-counter OTC drugs, which are like paracetamol. If you guys take in more dosage rather than helping your immunity to build naturally, if you guys keep on taking paracetamol, and it can cause a drug-induced liver injury and thereby causing liver cell damage and thereby leading to hepatic jaundice as well. So a moderate amount rather than overdosing with the drug can cause the hepatic jaundice. Now the last one is cirrhosis. Cirrhosis is the damage of the liver cells as well. So you learn about all these types of disease in pathology, so don't worry, just know the causes of the hepatic jaundice in this video. Now coming back to urine color and stool color. So urine color is dark due to the conjugated bilirubin that is present, and stool color which is normal or pale in color. Okay. Since we have completed hepatic jaundice, we'll move to the last type, which is post-hepatic jaundice or an obstructive hepatic jaundice. Now, what are the causes of this obstructive jaundice? As the name says, obstruction of the bile flow after the conjugation in the liver. I'll tell you about the conjugation later. Now just know the wordings over here that is being given. Now, what are the causes for the obstruction of bile flow can lead to the post-hepatic jaundice or the obstructive jaundice? What is the bilirubin type over here? It is mainly conjugated bilirubin. In the first case, we saw it was unconjugated bilirubin in pre-hepatic jaundice. Second, in the hepatic jaundice, we saw it was both conjugated and unconjugated. And in post-hepatic jaundice, we see it is mainly conjugated bilirubin or the direct bilirubin. Now, what are the functional tests that are conducted? Again, there is increased or elevated levels of ALP and GGT. So ALP and GGT are the two enzymes that are again found inside the liver and sometimes in bile ducts and bones as well. So ALP is alkaline phosphatase and it helps in the breakdown of the phosphate compounds that are important for the bile secretions. So if there is an elevated levels of ALP or alkaline phosphatase, it is considered to be post-hepatic jaundice, or GGT, which is gamma glutamyl transferase. Gamma glutamyl transferase. It is also an liver enzyme that is present in the bile ducts and hepatocytes. Hepatocytes is liver cells. And the normal range that are supposed to be for ALP is approximately 44 to 147, and for GGT it is approximately 9 to 48 units per liter. Now coming back to the common causes that are leading for post-hepatic jaundice are gallstones, the Gallstones are formed by bile that is being secreted, and it forms stones inside the gallbladder or in the bile duct, causing the obstruction and leading to jaundice. The second cause is pancreatic cancer. Cancer in the pancreas can also lead to post-hepatic jaundice. Then cholangiocarcinoma, again it is a cancer related to the bile duct region. The last one is bile duct strictures. The duct forming strictures is something like obstruction. It is a hardened versions of the bile duct, hardening of the ducts causing strictures, or the injuries that have happened near the bile duct can also form the strictures. The fibers form harder and cause the blockage of the bile duct. Now coming to urine color, it is very dark compared to the hepatic jaundice. The stool color is again pale or clay color. This is because of lack of bile pigments, and the bile pigments, where are they going? They are going to get deposited in the body, causing the jaundice. Now what are the other signs that you can see is that there is itching due to the presence of the bile salts in the body. So the person keeps on itching on his skin, or in the mucous layers there is a feel of itching due to the presence of bile salts, and fat malabsorption as well. So the fat absorption is not possible. So the fat absorption is not seen in these kind of patients. Now we'll just summarize whatever we have learned in this small diagrammatic representation. Now the types of jaundice, as I told, they are prehepatic, hepatic, post-hepatic. Now what are the points that you have to remember under prehepatic? It is caused by hemolysis, unconjugated bilirubin type, unconjugated and conjugated. Let me tell the conjugated and unconjugated part. So bilirubin is released from the RBCs. So whenever the hemoglobin, after the RBC dies or the hemoglobin is inside the RBC comes out, the bilirubin is being secreted, a yellow pigment that is formed after the breaking down of hemoglobin that is inside the red blood cells. So this bilirubin can be released in two forms after the hemoglobin breakdown. One is direct form, the other one is indirect form. The direct form is called as conjugated bilirubin. The indirect form is called as unconjugated bilirubin. Now what is this unconjugated bilirubin like? It is water insoluble. It doesn't get soluble at all, and it binds to albumin inside the blood and is transported to the liver. Now when it is transported to the liver, it is insoluble. It is sent into the intestine and is thrown out into the fecal matter. So that is how it works. Now coming to the conjugated bilirubin, it is a direct bilirubin wherein it is processed inside the liver and made into water soluble. After it is water soluble, it is going to be again excreted outside the intestine. So this is how conjugated and unconjugated are. So that is how a bilirubin is going to be deposited or accumulated inside the body if it is not thrown out through the intestine or simplified into much better urobilin or sarcobilin, which are excreted out into the urine or into the stool. So now in prehepatic stage, because of the breakdown of RBCs inside the human body, the bilirubin is going to get deposited there inside the body itself, causing the jaundice or the prehepatic jaundice. Now the second type, which is hepatic jaundice, caused because of cirrhosis or because of the pancreatic cancer or any other diseases, the liver cells are going to be damaged. Because of the damage of the liver cells, it can cause the bilirubin processing and excretion difficult. Now the last one, which is post-hepatic, there is obstruction in the bile duct or obstruction in the excretion of bile salts into the intestine, causing the bile to get deposited inside the body itself. So when the deposition happens, it causes post-hepatic jaundice. And what are the causes? As I told, because of the gallstones obstructing the bile duct, or there is a cancer in the bile duct, or there is a cancer in the ampulla of Vatal. And you learn about the different structures that is present near the liver and the pancreas and the bile duct, cystic bile duct. All those things in the upcoming anatomy videos based on digestive system. We'll be learning about it. Just know the structures and the diseases that are causing the jaundice. Causes that are leading to jaundice. Now this is an image of how a gallbladder cancer is going to cause jaundice inside a person. So as I told, itching, pruritus, it is a medical term for itching, and there is yellowing of sclera, the eye, and the skin is also yellowish. This is due to the blockage of gallbladder leading to gallbladder or the bile duct, leading to accumulation of bilirubin inside the human body. Now there is a chart, flow chart showing symptoms of jaundice. There is reduced appetite. The person doesn't feel like having food. There is an unexplained fat loss, and there is nausea and vomiting feeling. Then there is a mild fever, abdominal pain, flu-like symptoms, always fatigue. So these are the different symptoms of the jaundice. Since we have covered the classification of jaundice, we'll see the lab findings of each one of them. So lab finding is very much important for all the allied health sciences, because these lab findings are going to help you understand what is normal and abnormal inside a patient's body that is happening. So that is the beauty of whatever you're studying in theory that you're going to apply in your practicals. Now we'll see the different types and their lab findings. So pre-hepatic, as I told, it's unconjugated bilirubin levels are high, and liver function test appears to be normal, and urine color also appears to be normal, and stool color appears to be normal sometimes or dark sometimes. Next, the second type, which is hepatic, it has both conjugated and unconjugated bilirubin. The liver function test shows the increased levels of alanine aminotransferase and AST, which is aspartate aminotransferase enzymes, being increased in the liver enzymes. Now the urine color appears to be dark, and stool color appears to be normal or pale in color. Now coming to the last type, which is post-hepatic jaundice, the bilirubin type is conjugated bilirubin is more, and the liver function test shows the ALP and GGT, which is alkaline phosphatase enzyme and gamma glutamyl transferase enzymes, that are being increased or elevated inside the liver function tests. Then urine color is very dark, and the stool color is pale or clay colored. So this is important, just remember that. Now moving to the next topic, which is anemia. So everybody knows she is anemic, appears to be very pale. She doesn't have blood. After seeing the eye, after you ask her to show her eye, you say she's very anemic. If somebody doesn't have much blood inside their body, you say she's anemic. So what is anemia exactly? And then anemic patients are they feel difficulty while doing a lot of work, because the oxygen carrying capacity is reduced due to the lower levels of RBC count or the hemoglobin concentration. So we'll see the definition of anemia. Anemia is a reduction in the total red blood cell mass or the hemoglobin concentration or the hematocrit below the normal levels. So the person is said to have lower levels of red blood cell mass or hemoglobin concentration or hematocrit rather than the normal levels. Now we'll see the RBC size, which can be determined by various methods. One is microcytic hypochromic anemia. So based upon the RBC size or the size of a red blood cell, you can classify it into various types. The first type is microcytic. So as the name says, micro, smaller. So the RBC size is smaller than the compared to the normal levels. Microcytic, it is also called as hypochromic. Hypo, less, chromic is a blood, and anemia, hypochromic anemia. Now increased levels of MCB decreased levels of MCB and decreased levels of MCHC. MCV is mean corpuscular volume, or the average size of a red blood cell. You would have learned of you can learn MCV in the previous video, but I'll tell you the normal range over here. So MCV should be normally around 80 to 100 femtoliter, and the formula and the levels of increase or decrease are given in the previous video. You can go to my channel, or you can go into the description. You'll find the previous videos there. For the normal RBCs, WBCs, platelets, lymph, the immune system, everything is being covered over there. Okay, so you can go through the video and come back here and study about the various diseases that are caused due to the abnormalities inside the blood. Now microcytic or hypochromic anemia, coming back here, we have decreased levels of mean corpuscular volume as well as mean corpuscular hemoglobin concentration as well. So the normal hemoglobin concentration is 32 to 36 gram per deciliter, but it is decreased less than 32 is said to be hypochromic anemia. Now what are the causes for this is iron deficiency anemia. There is no proper iron content that is being delivered inside the body, or the person is not taking much of iron rich foods. Thalassemia and sideroblastic anemia, chronic diseases could also cause the anemia. So if the person is having cancer or is said to have jaundice, they are said to be anemic because of the lower concentration of RBCs or the hemoglobin concentration. Now let's move to the normocytic second type, which is normocytic or normochromic anemia. They have normal levels of mean corpuscular volume as well as mean corpuscular hemoglobin concentration. So these are normal. But what are the causes of normocytic anemia? So the causes, there is acute blood loss and hemolytic anemia. Acute blood loss could be during accidents. If the person is under an accident, there is a loss of blood due to an accident. That can also cause normocytic or normochromic anemia. Hemolytic anemia because of the RBC breakdown. Chronic diseases could be because of cirrhosis or any other cancer diseases, which can also cause the normochromic anemia. There may be bone marrow failure. During the transplantation of bone marrow, it can cause anemia as well. Now macrocytic anemia is the increased size of the RBC. There is an increased mean corpuscular volume, and the causes could be vitamin B12 deficiency, folic acid deficiency, alcoholism, liver diseases can cause the macrocytic anemia or the increased red blood cells. So here is a pictorial representation of what the anemia is caused based upon the RBC size. So as I told, it was microcytic, normocytic, macrocytic. Now under microcytic, you can see the MCV or mean corpuscular volume is less than 80 femtoliter, and the size in normocytic is around 80 to 100, which is normal, but the loss of less amount of RBCs can cause the anemia. Now the last one, which is macrocytic, has more than 100 femtoliter of MCV. Those are the three types based upon the size of the RBC. Now what are the disorders? There is mnemonic over here. Thales for microcytic, T stands for thalassemia, anemia of chronic diseases, iron deficiency anemia, lead poisoning, sideroblastic anemia. So all these types of anemias you'll be learning in pathology, so don't worry, we'll be learning in detail about them in pathology as well. Hemolytic anemia, anemia of chronic diseases, renal disease, acute blood loss, bone marrow failure, aplastic anemia. So all these can be the causes for normocytic anemia. Now coming back to macrocytic anemia, megaloblastic anemia, alcoholism, liver diseases, myelodysplasia. So these are the different disorders that are causing the anemia. Now we covered based on RBC cell size the different anemias. Now we'll see based on the cause, based on the what is the reason for the anemia to happen. One can be decreased RBC production. There is less amount of RBCs that is being produced, or it can be because of increased RBC destruction, or because of the increased RBC that is being broken down, or is hemolysis happening, or because of the blood loss. So there are three types based upon the cause. So the first type is decreased RBC production. So the RBC production that is happening inside the body is less. When does this less RBC production happen? Whenever there is nutritional deficiency, whenever the person is not taking iron rich food, whenever the person is not taking vitamin B12, or because of the folate. So all these nutrition when avoided can cause decreased RBC production, leading to anemia. Now bone marrow failure can also lead to the anemia, which is aplastic anemia and myelodysplasia as well. So you'll be learning about these diseases in future. Now know that bone marrow failure can lead to the reduced amount of RBC production. Then chronic diseases or inflammation can also lead to less amount of RBC production. Now increased RBC destruction, there is more number of RBCs that is being killed, that is because of hemolytic anemia, and there are two causes for the increased RBC destruction. One is intrinsic, the other one is extrinsic. Now intrinsic causes could be because of the hereditary spherocytosis. Hereditary is something which is taken from genetic. It is moving from father to daughter to the son. So it is hereditary. Spero is the spheric RBC destruction. G6PD deficiency, we learned about it in hepatic jaundice. You can again rewind back to G6PD deficiency. There is less amount of G6PD, that the RBC protective layer that is being secreted by G6PD is not produced inside the body. That can also lead to anemia. Next, sickle cell disease. I told the sickle shaped RBC cells can cause the hemolytic anemia. Now extrinsic causes could be autoimmune hemolysis. Sometimes the immune system might react badly to our own cells, causing the hemolysis of the cells. So that is what is autoimmune hemolysis. The second one, which is malaria, could be due to the transfer of malaria from one person to another by the mosquitoes. Malaria can also lead to anemia. Now DIC is disseminated intravascular coagulation. So there is this is a disorder that can cause the activation of coagulation system. So there might be clot formation inside the blood vascular system. That is DIC. Again, TTP. TTP is a thrombotic thrombocytopenic purpura, which you will be learning in the pathology. Now just know that it is a type of a rare life-threatening disorder, which is formation of again clots inside the body due to deficiency of some enzyme. We'll be learning that in pathology. Now the last type based upon cause is acute trauma surgery. Acute blood loss can be due to accidents or trauma to any body part that can lead to loss of blood, or due to surgery. If the surgery is a major one, the surgery can lead to blood loss as well, causing anemia. Again, chronic gastrointestinal bleeding, menorrhagia. Menorrhagia can also lead to blood loss sometimes, and people can be anemic. So as I told, types of anemia. There is aplastic anemia, vitamin B9 folate deficiency anemia, vitamin B12 deficiency anemia, iron deficiency, sickle cell anemia, or thalassemia. So these are the different types of anemias. So specific type of anemias, like why the anemia is happening is related to the deficiency or because of some genetic disorder that is happening inside the red blood cell, is dependent upon a specific type of tissue. Now we'll see iron deficiency anemia. As the name says, iron deficiency, there is poor diet, there is no proper intake of iron content and iron into your body, that will lead to iron deficiency anemia. It's the most common type of anemia, and this anemia is usually microcytic because there is a less iron content inside the body. The red blood cells would shrink into microcytic. Then the causes could be poor diet, blood loss, and malabsorption. Blood loss and malabsorption. Malabsorption is there is no proper absorption of whatever content that is being taken inside the body. Now symptoms could be fatigue. The patient appears to be very much tired, pallor, weak. All these things, these names are the representation of the different diseases of what might be the symptoms for the iron deficiency anemia. Now what is pallor? It is an unusual paleness. So if you see the person, he appears to be, he is not his hands and legs will appear to be rather white compared to reddish tinge that is seen inside the skin. So that is pallor. Now coming to thalassemia, the second type of specific types of anemia, it is a genetic defect in a globin chain production, and it can lead to microcytic anemia, and the target cells on peripheral smear can show the genetic defect of red blood cell production, globin chain production, leading to thalassemia. Now iron deficiency can be seen as symptoms wherein broken hair loss, if the person is having fatigue, headache, lack of concentration, if the person has cracked lips, stone corners of the mouth, mucus changes, there is burning tongue. Anemia, immunodeficiency or inefficiency of in the heart can also be caused because of anemia. There might be heartburn or anorexia and gastrointestinal complications that might be seen. There is pale and dry skin, feeling cold, and arched or brittle fingernails is possible due to iron deficiency. Now megaloblastic anemia is another type of anemia wherein it is a macrocytic, as the name says, bigger. Macrocytic is also bigger. The RBC cells are bigger than the normal usual size of an RBC. Now it is caused due to the impaired DNA synthesis. There is some impairment in the DNA production. These megaloblastic anemia might be caused due to B12 or folate deficiency, and the usual features or whatever patient complaint can be seen as glossitis or neurological signs that can be seen in a megaloblastic anemia. Now aplastic anemia, again pancytopenia due to bone marrow failure, and it is caused due to radiation or drugs or the viral infection that might affect the bone marrow which are involved in production of RBCs, WBCs or any other blood cells. Now normocytic anemia is the red blood cells is in normal size, but the aplastic anemia can be fatal due to radiations, drugs or viral infections that might cause. Anemia of chronic diseases, often they are normocytic. The RBCs is in normal size, and it is seen in chronic infections like the HCV, HPV, and cancer also sometimes, and autoimmune disorders can also lead to anemia, and there is increased hepcidin levels blocking the iron usage in the body. Now, hemolytic anemia is increased red blood cell destruction, and it can be seen in people with jaundice and who have dark urine and splenomegaly, wherein spleen is in bigger size. It has increased its growth. And in lab results, you can see increased levels of LDH, increased levels of bilirubin, decreased levels of hepatoglobin, and the reticulocytosis or the red blood cell destruction. So all these lab findings can determine the hemolytic anemia. Now, what are the different tests that are utilized to detect anemia? So one is ECR. It might be used for not just detection of anemia, but also to find out any abnormalities in the blood cells or the blood. So ESR is one type of test which is conducted to determine the normal RBC cell production and the values. Now we'll see the definition of ESR. It is the rate at which red blood cells settle in a vertical tube over 1 hour. Now, what are the normal levels of values for ESR to be determined and found as? For men it should be less than 15 millimeter per hour. So there will be a vertical tube. I'll show you an image of ESR rate, how it is being done in the labs. So for men it is less than 15, and for women it should be less than 20 mm per hour. If the ESR rate is increased, there are chances of infection or inflammation or autoimmune diseases. It can also be due to malignancy as well, that the ESR can be increased. In cases if the ESR is decreased or it shows lesser values, then it appears to be polycythemia or sickle cell anemia, or due to congestive heart failure, the ESR rates are low. Now, how do you method ESR? How do you measure the ESR? So there are various methods. One such method is Westergreen method, a gold standard method which is being used in all hospitals to determine the ESR. So what is the principle? Remember, all these questions are very much important. ESR is a sure question that might appear in your physiology exam. So as much as possible, just learn what the procedure is, understand the procedure is. If in case the hospitals or the colleges where you're learning about ESR, learn the procedure of ESR, because using ESR you can determine the patient blood anomalies that you can observe. Now, the first method, as I told, Westergreen method, it is a gold standard method. It is used worldwide. So what is the principle of the ESR? Under Westergreen method, here blood is mixed with an anticoagulant. So the anticoagulant that is used is 3.8% sodium citrate, and it is placed in a 200 mm long Westergreen tube. So you can see this tube, right? The tube that the person is holding, that is called Westergreen tube. So you're going to fill about 200 mm long Westergreen tube with the anticoagulant of 3.8% sodium citrate, and let it sit for 1 hour. After 1 hour, you can observe that a clear plasma is formed at the top, and that value is considered to be normal, the value of the person's ESR. So the normal values, as I told, it should be around 0 to 15 mm per hour for men, and for women it should be 0 to 20 mm per hour. So what are the advantages of Westergreen method? Is it is most sensitive and very standardized method, and it is also preferred by World Health Organization. So what are the disadvantages? Because it requires special pipettes. As I told, it's a Westergreen tube. It might cost a lot, and sometimes the room temperature can also lead to the wrong values of the ESR. Now, the second method is Winthrop method. Winthrop method is also another method to determine ESR. It uses a shorter tube compared to the Westergreen method. In Westergreen method, it is a 200 mm tube, and in this Winthrop method, you have shorter tubes which are 100 mm. And here the anticoagulant is EDTA. EDTA is ethylene diamine tetraacetic acid. It is a type of anticoagulant that is used to prevent the clotting of the red blood cells. Winthrop method, the second point says blood is filled up to the mark and sedimentation is measured after 1 hour. And the normal values in Winthrop method is 0 to 9 mm per hour, and women it is 0 to 20 mm per hour. And the advantages over here are it can be used to measure PCV, which is packed cell volume, in the same tube as well. PCV can also be measured here, and it requires smaller blood volume compared to the Westergreen method. You don't need to extract a lot of blood for the test. Disadvantages is it is less sensitive and can lead to little elevations in the actual normal levels. Now, modified Westergreen method is another method that is modified form of Westergreen's method. Here the EDTA is used as anticoagulant, and it is diluted in saline or sodium citrate, and used. Now, more practical in routine labs with automated analyzers. So it is conducted in automated analyzers, which is done by the machine. So all the Westergreen method and Winthrop methods are the manual methods, whereas modified Westergreen method is an automated method wherein the machine is going to calculate or determine the levels of the ESR. Now it is somewhat equivalent to the standard Westergreen method because it is automated analyzer and it uses the same principle as Westergreen method as well. Now, zeta sedimentation ratio ZSR is used to measure the hematocrit tube. They have a hematocrit tube over here, and the ratio is ratio is taken, not mm per hour. The ratio of the sedimentation rate is measured, not the actual normal values that we take millimeter per hour. It is less affected by anemia and is used mostly in pediatric and obstetric patients. So you can go do a little research of zeta sedimentation ratio as well, but I feel you guys need to focus more on Westergreen method as well as Winthrop method, because these are the gold standard methods and the methods that are adopted in usual laboratory environment. So remember, ESR is very much important. So ESR is erythrocyte sedimentation rate, as the name suggests. Erythrocyte is red blood cells. Sedimentation is to stack down, or whenever you filter out a muddy water and leave it for 1 hour, you can see a mud layer forming at the below because there is sedimentation happening. The mud that is being mixed inside the water gets settled down at the bottom. Similarly, erythrocyte is wherein the red blood cells that are mixed inside the blood is going to settle down and form a rouleau. You can see this rouleau, right? So it is going to stack one above the other and form a sedimentation. Sedimentation is to settle down. So they are made to settle down inside the tube for over an hour, and that is how an erythrocyte sedimentation rate being done. Hope you understood ESR, because ESR is very much important and it is usually asked question. Now the final method of ESR determination is micro USR. It is used using capillary tubes. I'll show you an image of capillary tube. It's a very small thin tubes that are being used to determine the blood volumes in small proportions, like for neonates or the babies that are just born. We can use those ESR determination with capillary tubes, and they are quick but they are not so accurate as Westergreen and Winthrop methods. Now, what are the factors that can cause increase or decrease of ESR? As I told in the previous slides, increased ESR can be due to infection, inflammation, pregnancy, malignancy, or anemia. There is increased ESR rate, and decreased ESRs can be due to polycythemia, sickle cell anemia, leukocytosis, congestive heart failure, and hypofibrinogenemia. So these are the different causes that can lead to the increase or decrease of erythrocyte sedimentation rate. Moving to the next type of test that is being performed in order to determine the normal levels of blood cells is PCV, which is more important. Now we have done ESR. This is also another mega important topic, packed cell volume hematocrit method. So we'll see the definition. The proportion of blood volume occupied by red blood cells is being determined. So that is how packed cell volume is determined. So normal values for male or men is 40 to 54%, and women it is 36 to 48%. And what is the cause that might lead to increased PCV or polycythemia vera, and dehydration can lead to increased packed cell volume values, and decreased values can be due to anemia or overhydration. Now PCV levels, as I told, clinical significance, the same thing is put over here. You can see the table. Now how is PCV determined? A normal blood volume has been shown 37% to 47%. In anemia, there is depressed hematocrit. You can see the blood cells that are forming a layer, packed volume. That is what is packed cell volume means. So there is a packed volume over there. So the RPCs over here, you can see the red packed cells, that is hematocrit. Now again, above that you have a buffy coat wherein white blood cells and platelets are forming a small layer over there, a pale white layer. So that is a buffy coat, above which is a plasma. This plasma consists of water, proteins, nutrients, hormones, etc. that is present inside a blood. Hope you understood the PCV over here. In the diagram, we'll be going through how the procedure of PCV is conducted. In anemia, again, there is depressed hematocrit. You can see there is very low amount of RBCs present inside anemic patient. As I told in previous slides that anemic patients have lower RBCs. Polycythemia, you can see there is increased amount of RBC production and elevated hematocrit that is being observed over here. Now, let's move to the next slide, wherein methods of estimation of packed cell volume. And Ventrobe method, microhematocrit method are the two methods that is being used to determine the packed cell volume. Both the methods are very much important. Keep in mind the procedure. So you use the Ventrobe tubes. They are filled with anticoagulated blood. Then the tube is centrifuged at 3000 revolutions per minute RPM for 30 minutes. So in 30 minutes, 3000 times it is going to rotate, centrifuge, and it can lead to RBC column that is going to determine the percentage of the total blood that might be inside the person, normal values, and it allows to estimate both ESR and plasma components at the same time. Now microhematocrit method, again it involves capillary tubes. Note the difference. In Ventrobe method you use Ventrobe tubes, and in microhematocrit method you use capillary tubes. The name only says micro. Whenever micro comes, remember the name capillary tubes. Tubes are sealed and again centrifuged at 10,000 to 12,000 RPM for 5 minutes, and a rapid and a minimal sample is required over here, and it is commonly used in pediatrics and field settings as well. So that is the difference between Ventrobe method. You have seen the Ventrobe tubes, right? So this is Ventrobe tubes. So these tubes are filled with anticoagulated blood, centrifuged or made to settle for 30 minutes, and the PCV is determined. So in microhematocrit, how are you going to determine the level? So you can see the small lines surrounding, right? Red blood-filled capillary tubes that are placed inside the microhematocrit. So microhematocrit is the meter that is used to determine the levels of the normal packed cell volume. So this is a capillary tube wherein you can see a clay seal down below to stop from leaking of the blood. Then the packed cell volume RBCs, then you have a buffy coat and the plasma membrane. plasma. So that covers how PCV is determined in microhematocrit method. What are the uses of PCV? How are you going to use PCV in clinicals? So you are going to use it to determine whether the patient is anemic or has a polycythemia. It is used to monitor the fluid balance. If the person is hydrated or dehydrated can be determined, and you can also evaluate the burns or shocks or hemorrhage. Burns, if the patient has a burns can lead to dehydration. Shock can lead to dehydration. Sometimes the patient shows the PCV levels to be low. Hemorrhage can be due to blood loss. So PCV also helps in determining or calculating the MCV, which is mean corpuscular volume or mean corpuscular hemoglobin concentration as well. Now PCV can produce certain errors sometimes. It can be due to improper mixing of blood sample. If the blood is not mixed properly with anticoagulant, the blood might clot and the readings might be wrong. Hemolysis during collection. If the blood is broken down, if the RBCs are broken down, the RBC when broken down is going to be no use. You can't determine a packed cell volume. Inadequate centrifugation. If the centrifugation is not done properly, the values might be wrong. There is trapped plasma in RBC layer. Sometimes plasma might go and get trapped in the RBC layer. Now, osmotic fragility test is another test that is conducted to determine the RBC's membrane. Now, osmosis, we know that it is diffusion through the layers that happens inside a liquid medium. Now, what is the purpose of this osmotic fragility test? It is used to determine the RBC membrane resistance to hemolysis in hypotonic solution. So, what happens when you put a RBC cell inside a lower concentration of salt inside its solution, that is hypotonic. So salt or any other medium that is a solution. If you put RBC into it, the RBC membrane should have the energy or the resistance towards the breaking down of RBC and letting the outside solution to move into it. So that is why osmotic fragility test is conducted. So if the fragility is increased, the patient might have hereditary spherocytosis or they might have an autoimmune hemolytic anemia. If the fragility is decreased, the patient might have thalassemia or iron deficiency anemia or sickle cell anemia. Now, blood indices, these are very much important to determine the normal values and abnormal values inside a human body. Now, MCV, yes, we have been learning about MCV from the very beginning of the site, mean corpuscular volume. So, under MCV, the average size of RBC is measured and the normal values is 80 to 100 femtoliter, and for a microcytic anemia, it is less than 80 femtoliter. Macrocytic anemia is greater than 100 femtoliter. MCH, mean corpuscular hemoglobin, amount of hemoglobin present per RBC cell is determined, and the normal is 27 to 32 picogram, and it can be due to low in iron deficiency or increase in the macrocytic anemia. MCHC, another type of blood indices. Mean corpuscular hemoglobin concentration, the average concentration of hemoglobin in the RBC, normal levels are 32 to 36 gram per deciliter. If it is decreased, it is due to hypochromic anemia. RDW, red cell distribution width. Now it determines the variation or the size of the RBC determination. It can be increased in mixed deficiencies for iron or vitamin B12 deficiencies. So that is the end of the video based upon jaundice, anemia, the methods to determine the normal blood volume by ESR or packed cell volume, and the blood indices as well as MCV, MCHC, MCH and RDW. So these are important terms, and normal values are very much important to remember. I hope you understood the video. If you didn't understand, go back to the video, as well as the notes are provided in the description. You can check the description for the notes link and download the notes and understand the concept easier. Subscribe to the channel in order to get more updates about the channel, and share it among your friends in order to get a wider community and a wider access to the notes. Thank you. Bye.